Assalamu alaikum friends, here you are with Sayyida OMAMA Shah, and today we will be discussing the adrenergic antagonists, the drugs that will block the activity of adrenergic receptors. So let's start. Adrenergic blockers, as the name indicates, that they will block the adrenergic receptors, the receptors that are responsible to stimulate the sympathetic activity. So adrenergic blockers are of two types. One is the alpha adrenergic blockers, while the other one is beta adrenergic blockers. The alpha adrenergic blockers will block the adrenergic receptors, while the beta adrenergic blockers will block the beta receptors. In this video, we're just going to talk about the alpha adrenergic blockers, and in the next video, inshallah, we will be talking about beta adrenergic blockers. So if we start the alpha adrenergic blockers, they are classified into selective alpha blockers and non-selective alpha blockers. The selective alpha blockers are further classified into selective alpha 1 blocker and selective alpha 2 blocker. Selective alpha 1 blocker will block only the alpha 1 receptor, while the selective alpha 2 blocker will only block the alpha 2 receptor. The non-selective alpha blocker will block both the alpha 1 and alpha 2 receptors. Now, the common thing between both the selective alpha 1 blocker and non-selective alpha blocker is that they will both block the alpha 1 receptor. I'm not going to talk about the selective alpha 2 blocker. It is because the selective alpha 2 blocker has no clinical importance. Just you remember that the example is yohimbine. Now, moreover, non-selective alpha blocker cause more powerful vasodilation and cause tachycardia as compared to selective alpha 1 blocker. Now, why this is so? It is because if you take this as a presynaptic nerve ending and this as a postsynaptic nerve ending, I discussed with you guys previously that alpha 2 receptor present on the presynaptic nerve ending will act as a brake such that it will stop the release of neurotransmitter entering into the synaptic space, while if it is present on the postsynaptic nerve terminal, it will act in the same way as A1 receptor. A1 receptor is responsible to cause blood vessel constriction. So here the A2 receptor present on the postsynaptic nerve terminal will also cause blood vessel to constrict. Now, if we give non-selective alpha blockers, then these blockers will block both alpha 1 and alpha 2 receptors. Thus it will induce more vasodilating property as compared to selective alpha 1 blocker, because they will only block the alpha 1 receptor. So there, in case of selective alpha 1 blocker, the A2 will be there to cause vasoconstricting property. Now, the non-selective alpha blocker causes tachycardia. How? Now, if we give the non-selective alpha blocker to the patient, it will block both the alpha 2 receptor present at the presynaptic nerve terminal and both the alpha 2 and alpha 1 receptor present on the postsynaptic nerve terminal. Now, once this blocks the alpha 2 receptor, then norepinephrine will rush into the synaptic space. Now here another receptor called as B1 receptor is present, and which I discussed with you guys previously, that B1 receptor is used to stimulate heart. So then this norepinephrine will then bind to this B1 receptor, and thus it will stimulate the heart, causing the contractility of heart to increase and the heart rate will increase. The condition is called as tachycardia, such that increased heart rate is called as tachycardia. So the non-selective alpha blocker is a more powerful vasodilator, and it causes tachycardia as compared to selective alpha 1 blocker. Now if you see, in both these cases they are used to block alpha 1 receptor, and alpha 1 receptor is responsible to cause blood vasoconstriction. So they will, when they block alpha 1 receptor, they will induce vasodilation. They will decrease the peripheral resistance. So when the peripheral resistance decreases, the BP will fall down. So I can conclude from this that both of these selective alpha blockers and non-selective alpha blockers are used to treat hypertension. Now if I talk about the selective alpha adrenergic blocker, so they may be alpha 1 blocker which will block only alpha 1 receptor, or they may be alpha 2 blocker which will only block the alpha 2 receptors. Alpha 2 blocker example is yohimbine, and it has no clinical significance, so we are not going to discuss this. Alpha 1 blocker is effective. The example drugs are prazosin, terazosin, doxazosin, tamsulosin, alfuzosin, and silodosin. As I discussed with you guys previously, alpha 1 blocker is used to treat hypertension, but at starting doses when we give the prazosin or maybe terazosin or doxazosin, it may also cause postural hypotension, and this is hypotension in the patient when the patient changes its position. Now, the tamsulosin, alfuzosin, and silodosin is a drug of choice for benign prostatic hyperplasia. The benign prostatic hyperplasia is a condition in which the patient's urine outflow is decreased. Alpha 1 receptor is also responsible to decrease urine outflow. So if we block the alpha 1 receptor, the urine outflow will enhance, and thus I can conclude that tamsulosin, alfuzosin, and silodosin is a drug of choice for benign prostatic hyperplasia. Now here I am going to mention one more thing, that alpha 1A receptor, the alpha 1 receptor is further classified into alpha 1A receptor and alpha 1B receptor. The alpha 1A receptor is present in the prostatic urethra, while the alpha 1B receptor is present in the blood vessel. So in alpha 1B receptor causes vasoconstriction, while the alpha 1A receptor causes the decrease in the urine outflow by contracting the sphincter muscle. So these tamsulosin, alfuzosin, and silodosin is selective for alpha 1A receptor. They will bind with the alpha 1A receptor and will block its activity, and thus will enhance urine outflow. So if in a person, if the person has normal BP but he has benign prostatic hyperplasia, so then the drug of choice will be tamsulosin, alfuzosin, and silodosin. But in elderly patient, if he has hypertension and benign prostatic hyperplasia, then the drug of choice will be prazosin, terazosin, doxazosin, because they are selective for both of these. They bind with both alpha 1A and alpha 1B. But if the person has normal BP and he has just benign prostatic hyperplasia, then we will prefer to give the patient tamsulosin, alfuzosin, and silodosin. Now, if I talk about the non-selective alpha-adrenergic blockers, so they block both the alpha 1 and alpha 2 receptors, and therefore they are called as the alpha 1 and alpha 2 blockers. Now, they may be reversible or they may be irreversible. The reversible are short-acting, while the irreversible are long-acting. The reversible include the phentolamine and tolazolene, while the irreversible include phenoxypensamine. Now, since this phenoxypensamine is a long-lasting drug, so it will be used in patients who has BP from a long time. So we have a condition called as pheochromocytoma, in which the BP remains high from a long period of time. So in that case, the drug of choice is phenoxypensamine. While if the person rises BP suddenly due to sudden stimulation of something, so the drug of choice will be then phentolamine and tolazolene. Here I am going to discuss the two conditions. One is cheese reaction and the other is clonidine withdrawal. In both these cases, the drug of choice is phentolamine and tolazolene. Now, what a cheese reaction is? Cheese basically contains thiamine drug, and this thiamine basically stimulates the sympathetic activity. Now, normally if a person takes cheese, so his sympathetic activity will not be stimulated. It is because in his gastrointestinal gut or tract, there is a presence of enzyme called monoamine oxidase. This monoamine oxidase will block or inactivate the thiamine. The thiamine will then not be available to induce sympathetic activity. But in a depressed patient, we give drugs which are MAO inhibitors. So there is absence of MAO. So in a depressed patient, if he takes thiamine, this thiamine will then induce sympathetic activity, because there will be no MAO in order to inactivate this thiamine. So that thiamine will then induces or rise the person BP. So for that sudden rise in BP, phentolamine and tolazoline is a drug of choice. Now, what a clonidine withdrawal is, so if you imagine this as a presynaptic neuron and this as a postsynaptic neuron, and I told you that the presynaptic neuron has A2 receptor which act as a brake, and E2 receptor is also present on the postsynaptic neuron which act in the same way as A1 receptor. Now, the clonidine is basically a drug which is used to press this A2 receptor. So this clonidine is basically used in order to decrease the BP. If a person has 160 BP, so it will reduce the BP to 120. Now the clonidine will continuously press the brakes, and the person continuously, if he is taking clonidine for many years, the brakes will be pressed and there will be no release of norepinephrine into the synaptic space. Ultimately, what will happen, there will be upgrade of neurotransmitters on this postsynaptic terminal. Now the receptors when upgrades. Now if the patient suddenly removes or inhibit taking or stop taking clonidine, then what will happen, the norepinephrine will rush into the synaptic space, and then in this case, then for norepinephrine there will be more receptors present on the postsynaptic neuron. So this will arise the BP to if he was if the clonidine reduces BP from 160 to 120, now this clonidine withdrawal will rise the BP to 220. So that is the severe case. For that means this is sudden rise in BP, the drug of choice will be phentolamine and tolazoline, which is so short acting drug. Finally, thanks for watching all my dear friends. Stay blessed and stay tuned for more uploaded videos. Allah Hafiz for now.